All right, guys. Test. Here we go. Let's try this one again. Thank you, everybody. Well, hit second start. And 1, 2, 3, and go. Thank you, students, for Nursing 504 for coming to our presentation on chronic migraine sufferers. I'd really like to thank the team I got to work with. It's been a very fun and exciting semester. This has definitely turned out to be a very interesting topic to get to dive into. So why would we want to look at chronic migraine sufferers? Well, the question we asked ourselves is can we use some non-pharmaceutical interventions for patients suffering chronic migraine? Now, as we got into this, we figured out that the problem was bigger, but definitely we felt that this was important as more than 4 million adults experience daily chronic migraine in the United States. And there is a cost associated with this, not only to the quality of life to the patient, in terms of lost productivity and lost ability to participate in family, social, and leisure activities, but also it puts a strain on relationships that we have within society. Patients who are chronic migraine sufferers also experience an increased healthcare utilization, and there are barriers to receiving an accurate diagnosis. There's certainly a financial burden. In Migraine Research Center estimated in 2015 that we spent more than $5.4 billion on just treating chronic migraine. But employers are anticipate, according to the Integrated Benefits Institute, so employers who will offer benefits such as health care or paid sick days, disability insurance, etc., are averaging around $84,000 per 1,000 employees. So when you think about it, that's ultimately saying that we're spending $8,000 a year, every employer is on every employee, just on chronic migraines. And this doesn't even take into account also that the fact that it attributes to about 1/3 of our lost work time in the United States. So, and then of course, a long-term study of 600 chronic migraine patients showed that they missed an average of 37 days of work and had to use 13 disability days. And then there was an indirect cost related to their migraine of almost $8,000. So as you can see, this has a heavy cost on society. So we really wanted to know how we could make an impact on this. And so the actions we took as a team is we did go to SINHAL and PubMed to try to find what would be best practices to see how we could improve quality of life without using medications or increasing medications or maybe even hopefully decreasing medication use. But when we took our 40 articles and we split them between our team of 4, we didn't really feel like we had a clear answer. So we did consult with a medical librarian. We did not use the one at Washington State University. We used one that I work with, Robert Mendenhall at Kootenai Health. Her name is Carly Vesely, and I have a great relationship with her, and I wanted to be able to sit down with her. I do plan on meeting the librarians and using them more in my nursing career at Wazoo, but for the short time period and the crunch we were in, I just felt that this was best. And this would also give us some resources that we could use through the Mayo Clinic that we wouldn't have had access through at Wazoo. But we just wanted to look at the standards of care and we wanted to look at the standards of diagnosis. So what is the population of chronic migraine sufferers? About 84% of them are women, and 20% of this patient population will suffer disabilities, will be considered disabled. They're first must define episodic versus chronic migraines. So this comes down to whether or not you have more or less than 15 headaches a month. Now, not all of these headaches in a month will necessarily be migraine headaches. So we are expecting more than half of them to actually meet this migraine criteria. Now, there can be several types of headaches and headaches that will be considered migraines. And this is either at the episodic or at the chronic level. So you could have migraines without aurora. And as you can see, there's several boxes to check to diagnose that, just like there is several different boxes to check to try to diagnose if it's a migraine with typical aura. Now, there is a chronic migraine condition called medication overuse. So in these patients, their episodic migraine hasn't actually gotten worse. It's the medications that they were using that has created the worsening of their headaches. And the Headache Classification Committee of the International Headache Society does say that in order to accurately diagnose medication overuse chronic migraine, we must remove the patient from those medications and see how they respond. So this is definitely something you would want to do with a qualified provider. There are plenty of other types of migraines, from tension, headaches, retinal headaches, cluster headaches. So as you can see, it takes a lot of work to actually diagnose from headaches to episodic chronic migraine and episodic and chronic migraines. So there's definitely risk factors associated both with episodic migraines and for patients who are suffering headaches an episodic level and going into being this transition into a chronic migraine. So for example, 50% of people with depression supposedly have a migraine disorder, but chronic pain disorders, anxiety, obesity, medication overuse, nutritional deficits, and musculoskeletal disorders are just some of these underlying issues that will need to be addressed as we look at our migraine patients in our office. So currently, as we looked at what is the standard of care, and ultimately as it relates to the pharmaceutical interventions, there's a standard of care around what types of medications you want to use to address the acute phase of the headache. And then also there are prophylactic medication or prophylactic management that patients can take on a daily basis and hopefully in an effort to ward off a headache, or at least reduce the severity or the duration that they will experience that headache. But when it came to trying to find a standard of care for non-pharmaceutical interventions, it became very, very difficult, as it really depended on the underlying physiology. For example, if the patient's migraine is related to exercise, while yes, it seems natural looking at the evidence to say we need to reduce their obesity and increase their exercise more, I don't think any provider wants to actually write a prescription for something that will actually cause a headache. Another example is there are migraine conditions that may actually be related to a nutritional deficit. And so dietary changes could definitely help the patient have a higher quality of life. But that's not the type of intervention you're going to want to use in a migraine whose underlying factor is really related to a musculoskeletal disorder or someone who may actually benefit more from physical therapy. So again, as we come to the intervention, we just looked at this complexity and numerous causes, and we realized that we needed to look at this picture a little bit differently. So that's going to bring us to our proposal, but we'll go ahead and finish off the PICO question. As we looked at our 40 articles, we also wanted to look at how we wanted to measure our outcomes. Or we know we're going to make a difference if we institute a change in our practice. And so under quality of life, there are two different instruments or tools that we can use. One of them, the MIDAS, is a 5-item self-reported tool. And then there's also the Migraine Disability Assessment Score and Headache Impact Test 6 that we could examine. We should also look at creating a headache diary, maybe something a little bit structured and formal template that we can use with our patients, that all of our providers could use. This will definitely help us to improve our diagnoses, but also help our patients to understand and differentiate between their symptoms and maybe identify particular causes. We should definitely look at measuring or having self-reports of duration, the interventions, and how they worked as far as intensity and that duration from those patients. And of course, the whole object is to reduce medication usage wherever possible. So that brings us then to what is our proposal, and we definitely need more stakeholders at the table. For example, we do need to understand from billing what we can do with our services and how we can bill as we expand our practice or look at to try to specialize or look at to coordinate ways for our patients with migraines. There's also need to build PT, OT, some psych services that we want to be able to work with. But the first question then is, what should be the role of our primary care providers in our office? I mean, we're definitely, most migraine sufferers will come to see their primary care provider first, but we need a headache specialist to confirm diagnosis. But certainly there's evidence to show that nurse practitioners are at that point, that are at a unique point to be able to coordinate and help coordinate this care, and that we play an important role in helping patients understand how to use their medications. And the fact is that seeing specialists in the area is a long wait list. And so If we want to be able to make a difference, then we're going to need to. But we want to argue that we need to train a specialist, because when you look at just the complexity of how you would move through and make a diagnosis and a treatment plan, we definitely want to make sure that someone is our specialist in the office. And we definitely wanted to point out from the American Headache Society, we do want to reduce prolonged and frequent use of over-the-counter pain medications and only use opioids as a last, not a first-line treatment for recurrent headache disorders. So our proposal is that we would like to have a nurse practitioner be a migraine navigator to coordinate this care and train as a headache specialist. They'll be able to help lead change within our office. And we do have a reference list, and we'll go ahead and take questions and answers. That one is 30 seconds over, but I don't think it's a big deal. It's the first time it's been over. I'm almost always under. I think we're good to go. I just stumbled in a couple places. I'll practice more before Monday. I look forward to your input. Thank you.